Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM. Cardiology seminars is brought to you by Triple N Media. On our YouTube channel, we have more than 200 cardiology lectures. We welcome you to watch those videos, and we also kindly request you to subscribe to our YouTube channel so we can keep you abreast of our latest editions in the cardiology seminars. The information provided here is for education and entertainment purposes only and is not a medical advice. If you want me to prepare a particular topic, I will be happy to do the research and create a video for your benefit. If you would like to get a copy of my cardiology rotations manual, please stay tuned till the end of this presentation, and I will tell you how you can get a copy of my cardiology rotations manual, which has more than 175 pages of pertinent information on maximizing your experience on your cardiology training rotations. The featured presentation for this seminar is ACLS Supraventricular Tachycardia Differential Diagnosis. This is a very important topic not only for ACLS but for those who are working in the emergency room, the intensivists, the cardiologists, and the nurses who are involved with dealing with patients with rapid heartbeats. Whether they have narrow QRS complex or wide QRS complex, we're going to tell you how you can differentiate the various types of supraventricular tachycardias and come to a proper diagnosis. Here's an electrocardiogram. You got 30 seconds. What is your diagnosis? Here's the next one. What is your diagnosis? Whenever we are looking at electrocardiograms, we not only look at the rate, but we also look at all the other features, the entire electrocardiogram. So it may give us clues as to what's happening inside the heart. Okay, what is your diagnosis here? Attempt at diagnosing a supraventricular tachycardia. Let's look at some of the basic things we need to focus upon. First thing is, what is the ventricular rate? And what is the atrial rate? Next, are the RR intervals regular? If you're dealing with a RR interval which is regular, it could be sinus tachycardia, paroxysmal atrial tachycardia, it could be flutter or junction rhythm. If you're dealing with a varying RR interval, that is irregular rhythm, you may be dealing with atrial fibrillation, multifocal atrial tachycardia, or a patient with WPW. Then we need to look at the relationship between the P and the QRS complexes. The P wave may be in the normal position in patients with sinus tachycardia or paroxysmal atrial tachycardia. The P wave may be buried in patients with atrial flutter or junctional tachycardia. The P waves may be invisible in patients with atrial fibrillation. That's why I said the P waves may be coming before the QRS complex, buried in the QRS complex, or coming after the QRS complex. The QRS duration, which I talked to you about WPW, sometimes we get rate-dependent right bundle branch block. That is, at normal heart rate of 80, the EKG may look narrow QRS complex, but when the heart rate goes to 130, 140, you may see a bundle branch block. That's called the rate-dependent bundle branch block. Then we need to know, does this patient have pre-excitation? A previous electrocardiogram might help us with that regard. Is there a presence of delta wave? Did this patient have similar arrhythmias in the past? So reviewing the electronic record can shed a vast amount of information about what is happening with this patient, so that you pick up from there and you put the pieces of the puzzle together to diagnose the supraventricular tachycardia. And what is the history? Does this patient have recurrent rapid heart rates which are coming on suddenly and then going off suddenly? Or maybe when the patient strains, the arrhythmia goes away? Then we may be dealing with paroxysmal atrial tachycardia or junctional tachycardia. These are paroxysmal rhythms, and the onset and the way the arrhythmias terminate may help us to diagnose certain arrhythmias along with EKG findings. Confused? Don't worry. We will walk you through step by step how to diagnose a supraventricular tachycardia and how to come up with the right diagnosis. Whenever we are dealing with supraventricular tachycardia, for example, let's start off with a narrow QRS complex tachycardia. When we are looking at the narrow QRS complex tachycardia, we could be talking about paroxysmal atrial tachycardia, PSVT. The rate is between 160 to 225. It could be atrial flutter with 1-to-1 conduction or 1-to-2 conduction, 1-to-1 conduction or 2-to-1 conduction, and the atrial rate could be anywhere from 250 to 340, whereas the ventricular rate may be same or half of that in most cases, or 1/3 of that. Atrial fibrillation is where the atrial activity is more than 400 beats per minute. No chaotic random activation of atrial myofibrils, and the ventricular rate can range anywhere from 30 to 300. Multifocal atrial tachycardia is seen in mostly patients with multifocal atrial tachycardia is seen in patients with COPD. It is characterized by a varying RR interval with varying P wave morphology. Junctional tachycardia is anywhere between 100 to 200 beats per minute, and it is characterized by a retrograde P wave, which we may be able to identify in most cases. Sometimes we may not be able to see it if the P wave is buried inside the QRS complex. Wolff-Parkinson-White syndrome tachycardia is quite complex and could be confusing, and we may mistake this to ventricular tachycardia, but we have to understand most patients with Wolff-Parkinson-White syndrome, when they have tachycardia, the underlying rhythm is most likely atrial fibrillation. So the starting point is they have a varying RR interval. You may see P waves or you may not see P waves if you're dealing with the atrial fibrillation. The other thing is the QRS morphology changes from beat to beat. And that's another important thing to keep in mind. And if you have access to their previous electrocardiogram, and if you look at that, and if the patient had a delta wave, then it is a then it's a good tip that you may be dealing with the WPW, atrial fibrillation with rapid ventricular response and aberrant conduction. Too many terminologies. The mechanism of arrhythmias could be related to automaticity, like in patients with paroxysmal atrial tachycardia or atrial flutter, paroxysmal atrial tachycardia or multifocal atrial tachycardia or junctional tachycardia, whereas re-entry, that is going in a circuit, which is usually seen in patients with atrial flutter, where the circuit can be within the atrial wall, or it could be in the AV junction for paroxysmal supraventricular tachycardia or junctional tachycardia. I mentioned about this automaticity, which is seen with PSVT, sinus tachycardia, junctional tachycardia, multifocal atrial tachycardia. The reentrant ones are atrial flutter, atrial fibrillation, AV nodal re-entry, and atrioventricular re-entry. Before we proceed with so keeping all these things in mind, and let us try to decipher what we are dealing with. Here we have a tachycardia. The RR intervals are grossly irregular. We don't see any definite P waves, maybe some glitches here, but nothing really to speak of. And of course, you have some intraventricular conduction delay. So we have some STT changes. So this is an example of an atrial fibrillation with rapid ventricular response and some non-specific STT changes. There is also left axis deviation and left anterior hemiblock. We need to put all the pieces of the puzzles together. If you are dealing with a bifascicular block in a patient with atrial fibrillation, then we may be concerned about higher degrees of AV block down the line. Okay, let's look at the next electrocardiogram here. Okay, what do we see here? This looks like a fairly regular tachycardia. The RR interval is, if it's 3 boxes here, it is 100. It is more than 3 boxes, it's like 110, 120. So when you're looking at 120, you multiplied by that 2, that's 240. So then we are looking at maybe an atrial rate of 240 to 250, and we can see some clear distinct P waves here. So this is a case of a atrial flutter with 2-to-1 conduction. We also see a shift in the axis here. 1 and AVL are negative, and we also have loss of R waves anteriorly along with the atrial flutter with 2-to-1 conduction. Okay, here we have a different scenario of the one we looked at the first one. We looked at the Here we have a different scenario. Again, we have a varying RR interval. Whenever you see varying RR interval, you need to think about atrial fibrillation. And because we have a wide QRS complex here, we need to find out if this wide QRS complex was there before, or is it something that has developed new with the rapid heartbeat. This is of a right bundle branch block pattern because we have a terminal slurring of the S waves in the lateral leads. We also have left axis deviation, left anterior hemiblocks, and significant ST depression in the anterior leads with some positive deflections in the anterior leads. So we need to see what is going on here. Obviously, we have atrial fibrillation with the rapid ventricular response, right bundle branch block, and some STT changes. And if this patient had chest pain, we would be concerned about posterior infarct because of tall R waves, ST elevation, and T wave inversion, which will be a mirror image of a posterior acute infarct. So these ST segments are of a concern. Let's move on to the next one. What do we see here? So here we have a regular heart rate, which is approximately 160 per minute, 150, 135. So we have a regular P wave before each QRS complex. The QRS complexes are narrow, and we can follow the P waves in most of these leads. So we are dealing with a sinus tachycardia. The sinus tachycardia is anywhere between 100 to 160 beats per minute. Junctional tachycardia can also be between 100 to 200 beats per minute, but generally you wouldn't see this regular P with a regular PR interval in a junctional tachycardia. We see some non-specific T wave changes here. And here is another example. We see the P waves, the QRS complex, P QRS complex. The rate is, if these are two big boxes, that's 150. Then it is 160, 175. So here we have 175 rate, which is approaching that of a paroxysmal atrial tachycardia. In patients with paroxysmal atrial tachycardia, we need to see how does the tachyarrhythmia begin and how does it terminate. That may help us a great deal in trying to determine the origin of the tachycardia. And of course, if you do a carotid sinus pressure, that's one way to slow the ventricular response and look for hidden P waves, like as we see here, hidden P waves, which are at a rate of almost close to 300 beats per minute with a 1-to-1 conduction, more or less. So this is kind of a serious situation if you are seeing this patient in the emergency room. Okay, here we have a P wave and another P wave, P wave, P wave, P wave, P wave. The ventricular rate is 1, 2, 3, approximately makes 109. So we got about 200 plus atrial rate with ventricular rate being 100. So this could be, it's not flutter because the atrial rate is below 225. So we could be dealing with PAT with block. Whenever you think about PAT with block, we need to be concerned about digitalis toxicity. Okay, let's look at this one. What do we see here? So here's an example of a supraventricular tachycardia with a heart rate approximately, let's see, these lines are also smudged, about 130, I would say. So the atrial rate is 260. And do we see any definite P waves? We see some notches here, notch here, notch, notch, notch. And if you can see it here, one notch here, one notch here, one notch here. So this is atrial flutter with 2-to-1 conduction. The SVT changes look far better than the ones we saw in the other electrocardiograms. Let's look at this one. Again, we are seeing varying RR intervals. If you have an irregular rhythm, Whether it's wide QRS or narrow QRS, always think about atrial fibrillation. Now let's see what else we can detect from this electrocardiogram. Of course, we have wide QRS complexes, which may make us think about the possibility of a WPW. An old record or electronic health records may help us to see if this patient had WPW in the past. Anyway, if the patient has WPW, you don't use beta blockers, you prefer procainamide to slow the rate down. Okay, here's another example of a narrow QRS tachycardia. Again, the RR intervals are varying and we don't see any P waves. Let's see if we see any P waves. Like I see a P wave here, 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 which are kind of sort of more clear than in the previous examples. So if you see P waves like this, and you're dealing with a patient with COPD, you need to think about multifocal atrial tachycardia. They can trick you with the history. A 68-year-old chronic lunger comes into the emergency room with palpitations, and here's the electrocardiogram. What is your diagnosis? PSVT, sinus tachycardia, atrial fibrillation, atrial flutter, multifocal atrial tachycardia. Well, the diagnosis most appropriate would be multifocal atrial tachycardia because of the history of COPD. That's where we see this multifocal atrial tachycardia very often. Okay, what is the example here? Here's an example of a heart rate which is about 125, and we see inverted P waves here with a short PR interval. Whenever we see something like this, we need to be concerned about junctional tachycardia. In junctional tachycardia, more often we see a rate close to like 150, 160, 170 with a retrograde P wave coming after the QRS complex, like a little notch. We might have an example and I'll try to show you. But you can see the P wave before the QRS, it could be buried in the QRS, or it could be coming after the QRS complex. So think about junctional tachycardia when you see these kind of changes. And here is an example of a fairly regular tachycardia. We don't see any clear P waves in the location we are supposed to be. It is not clear, but here's a little notch here we see. So this could be a junctional tachycardia, like here's a notch in the T wave. And this could be a junctional tachycardia with retrograde P waves. Here's an example of a slow ventricular response, but we have an arrhythmia. Can you identify the arrhythmia? Well, this is atrial flutter at a rate of 300 per minute with very slow ventricular response. Whenever you see atrial flutter with very slow ventricular response, you need to be thinking about, is this related to drugs like beta blockers or digoxin? Is this related to sixth sinus syndrome? Or is this related to any other underlying condition? And these patients may end up needing a pacemaker because if they have a very severe bradycardia which is symptomatic, they need help. So ladies and gentlemen, this is a very quick overview of ACLS supraventricular tachycardia differential diagnosis. And if you would like to get a copy of my cardiology rotations manual, please send me an email at drniknikam@gmail.com and I'll be happy to send you that copy. And please do subscribe to our YouTube channel where we have more than 200 cardiology lectures for your benefit, whether you're a nursing student, a medical student, medicine resident, or a cardiology fellow, you'll find something of interest in your field. This says the cardiology seminars are brought to you by NNN Media, and please do subscribe to our YouTube channel, and I will see you in the next video.